Hi, this is Manos Boulakis from Minneapolis Heart Institute. It is a great pleasure to introduce again Dr. Tony Spaedy from Missouri Heart Center. Dr. Spaedy has a tremendous experience in complex PCI and CTO PCI, and he's going to present case 61 for the second edition of the Manual of CTO Interventions. Tony, thank you again very much.
Thanks, Manos. Yeah, this first case is just an example of some options in a patient that was not a surgical candidate, that had a large vein graft aneurysm from a vein graft that was almost 20 years old, and what we did to deal with the vein graft and get the native CTO open. It's just a little cartoon showing a diagram of how to do scratch and go, which is what we did use to get moving antegrade in this case. You can see this is a patient with a very poor ventricle. We might do this case with Impella today, but at the time we did this case without hemodynamic support. I think this is the key reason the surgeons did not want to consider her for a second bypass surgery, but she did have significant symptoms, including angina and heart failure symptoms and viable myocardium. You'll see she's also got mitral regurgitation and very severe native coronary artery disease. It just shows you that her her LAD has terrible disease, but also if you look in a more caudal REO type view, this vein graft to an occluded circumflex. When you first look at it, your eye goes to this severe lesion proximally, which may be a part of her current presentation, and that's where our eye went initially. But as you watch the vein graft, you see little collections of dye outside the vein graft, so you can see little collections, little balls, almost like Christmas tree decorations coming off of the graft, where the dye is going out into a large pseudoaneurysm with thrombus. So this is just a CT. This lady had a couple of relatively large pseudoaneurysms. This one is 3.6 centimeters by CT. And our plan on this case was, because of her symptoms and because of the way the vein graft looked, ideally we would coil the vein graft to lower its risk of continuing to expand or rupture, and potentially open the native circumflex at the same time. So you can see we bring our catheter down into the proximal circumflex. We put the one wire into a small branch. The CTO actually just comes down to the left of that wire, and we had trouble sorting out the cap and getting started, so we did dilate the proximal segment and then use a fielder wire to knuckle. You can see it's starting. We think we're getting started in the right architecture with this wire tip that's on the left. The wire on the right is just a workhorse wire that's setting in the marginal as much as anything for stabilization and reference. And here we get a knuckle started. And when we do a retrograde injection, you can see the knuckles coming down nicely toward the bifurcation in the circumflex. So now we have a relatively short distance we need to connect. Our ideal goal was to try to save this bifurcation, although that probably would have done okay if we didn't necessarily save the AV groove branch. So we did carefully bring a microcatheter down this diseased vein graft, and you can see it comes up nicely, and then we bring a retrograde. This was also a Pilot 200. Here's our antegrade wire sitting. It looks like it's straightened out a little bit, but our retrograde wire with a little bit of manipulation was able to drive along this antegrade wire and out into the aorta and eventually into the guide. You can see here it goes out into the aorta, but we pull it back, it drives into the guide. And then we just did reverse cart in that fashion. So now we bring our externalization wire through the whole system, and this is now an antegrade balloon coming over our externalization wire, so it's coming down antegrade, and we're dilating the proximal circumflex. Go to the next picture. After we get it dilated and stented, we bring down a series of coils. So we try to coil the distal part of the graft. These are cooked coils coming down through a cooked microcatheter. You can just see you slide them down the microcatheter, they coil up automatically, push it all the way out the microcatheter, and then you can withdraw the catheter. So we put coils, these are I think 5 or 6 millimeter coils. You see we put coils distally, and then we put a couple coils proximally, so we try to seal the outflow and the inflow to decrease pressure to the aneurysmal segment. And here's an injection antegrade where you see the dye going up, but mostly stopping at the coils. And now here's an additional injection antegrade into the graft. And you can see there's very little dye going antegrade now into the graft. You can see all 4 coils. We could have used more coils if we were concerned about getting it thrombosed well. And then here's the final picture antegrade, where you can see the circumflex has good flow antegrade. We still have some flow up into this initial coil retrograde, but those will usually go ahead and thrombose off nicely.
Great, thank you, Tony. That's a fascinating case. Quick question on the coiling. There's a controversy. In this case, obviously, you did have very diseased vein graft, so you want to close it definitely. But let's say sometimes you have a graft that's not aneurysmal, it's just diffusely diseased. Do you typically coil those as well, or do you let them close by themselves? So what is your preferred strategy for these vein grafts that are not like this one?
Right, that is controversial, and it seems like you get different opinions. My personal approach is to leave the vein graft alone and not coil it, and kind of let it close on its own, which typically happens. These are old grafts, and a lot of times they're destined to fail in the next year anyway. But we usually leave it alone.
Great. Well, thank you very much for a wonderful case.
Great, thank you.